he's prone, right? And I'm going to take his knee and I'm going to bend it. And I could stabilize and stuff like you do with your length testing, but I'm mostly looking for neural tension. I was kidding when I said it's a hard one. This is all there.
Oh.
Everyone's like waiting for the variation. I was joking. This is it. And then I'm looking for, does that reproduce your symptoms? Do you have any symptoms with that? Any pain with that? Now, the thing with this one, it's hard, is that you don't have really something that you can reproduce with. So, you know, you can put them, your book actually talks about not doing this, not bringing them up into more of an extension. Sometimes if you do that, with that, you get a little bit more stretch, so where that femoral nerve comes in contact with the hip flexors, you get a little bit more, but your book talks about not doing that, just looking for, does this reproduce your symptoms when we put you in this position? So what do you see as a little bit of a clinical challenge with this then? Because if it was a quad problem, would this reproduce your symptoms? Yeah, so then you're differentiating between what are they describing. That's where those descriptors come in, you know, is there tingle, is there burn, what am I feeling or having with that? Or I can also, now when I test this, I'm getting all of those, but if you wanted to make it more focused on lateral femoral cutaneous, what do you think you would do? So think about lateral femoral cutaneous. Say that again, Chris? A deduct, do you guys agree with that? I would add in, you okay in your quad? I would, could have done without your foot in my mouth. My fault, therapist's fault, therapist error. So I can bring in some hip extension and a deduction to more bias lateral femoral cutaneous. So there's things that you can do to bias the nerves. That's the main one. The rest of those would be would all be tensioned when I'm tensioning femoral.